I'm Dr. Guy Young from Children's Hospital Los Angeles in Los Angeles, California. Welcome to this educational activity on extended half-life replacement factors for the management of hemophilia A. So let's get started.
The following podcast is part of a certified educational activity titled Defining the Role of Extended Half-Life Replacement Clotting Factors in the Modern Management of Hemophilia A. Access the entire activity and complete the post-test at www.peerview.com/XAQ. Downloadable slides and practice aids are also available.
As many of you know, hemophilia A is an X-linked inherited disorder attributed to a deficiency in clotting factor VIII. The incidence of this secondary hemostasis disorder is approximately 1 in 5,000 male births with no ethnic or racial predilection. Severe hemophilia A, factor level less than 1%, typically presents in male infants with either spontaneous bleeding events or excessive bleeding or bruising with mild trauma, such as circumcision, vaccination, or learning to ambulate. Despite being a rare disease, hemophilia A can have a significant impact on patient health. Without treatment, bleeding events may be life-threatening or result in chronic disability from recurrent hemarthroses and intramuscular bleeding. Presently, the standard of care for hemophilia A is treatment with replacement therapy, which can be either on demand, where infusions of factor VIII are given to treat a bleeding episode, or prophylaxis, when regular infusions of clotting factor concentrates are provided to prevent bleeding episodes. In this regard, prophylaxis is considered optimal for care for children and adults with severe hemophilia A because of its proven ability to reduce joint and other bleeding episodes. However, a one-size-fits-all approach to prophylaxis is not ideal, potentially leading to overtreatment in some individuals and undertreatment in others. Moreover, a generic plan fails to take into account a patient's bleeding phenotype, lifestyle, and personal preferences. Yet despite the clear need to personalize prophylaxis in patients with hemophilia A, there are numerous barriers impeding the development of optimal regimens for individuals with this secondary hemostasis disorder. Foremost among these challenges is the high infusion frequency required, as standard recombinant factor VIII products have relatively short half-lives, about 8 to 12 hours. IV infusion is usually required up to every 2 days for patients with severe hemophilia A in order to maintain factor VIII levels greater than 1%. The inconvenience of such frequent IV infusions is also a challenge and may lead to adherence problems, particularly in adolescents. Frequent infusion may be particularly difficult in patients with poor venous access, which is often the case in children. In such instances, injections can be distressing for both the child and the caregiver. Fortunately, several protein modification strategies have been explored to extend the half-life of exogenous factor VIII, with the goal of supporting either higher trough levels with a standard infusion interval or extension of the infusion interval needed for successful prophylaxis. In fact, 2 such approaches for extended half-life factor VIII have been validated and are available to us in clinical practice. The first approach is Fc fusion. Fc is a portion of human immunoglobulin G that can be attached to proteins with the intent of extending their half-life in the circulation. IgG proteins have a half-life of approximately 3 weeks in circulation. This long half-life is mediated through binding to the neonatal Fc receptor, FcRn, and processing through a naturally occurring recycling pathway that delays destruction of factor and recycles it back into the bloodstream. The other method that's been used to extend the half-life of factor VIII is pegylation. This involves the attachment of polyethylene glycol, or PEG, which is a large molecule that inhibits the ability of conjugated proteins to be cleared by the kidney. In addition, attachment of PEG interferes with binding of the protein to clearance receptors in the liver. Importantly, PEG is cleaved upon activation of the factor, so it functions normally in the coagulation cascade. Presently, one extended half-life factor VIII product that employs Fc fusion, F-Moroctocog alpha, and 2 that use pegylation, Rurioctocog alpha Pegol and Damoctocog alpha Pegol, are approved for the management of patients with hemophilia A. Clinical trials have shown the mean half-life extensions for these products are 1.5 to 1.8 times that of standard factor VIII products. A number of investigational extended half-life factor VIII products, such as Turoctocog Alfa Pegol and BIVV001, are also in various stages of clinical development. When we come back, I'll be joined by Dr. Miguel Escobar, who will lend his expertise to a discussion of current clinical trial data on extended half-life factor VIII products for the management of patients with hemophilia A. So stay tuned, and we'll be right back. Welcome back. Joining me today is my colleague, Dr. Miguel Escobar. Dr. Escobar is a hematologist from the University of Texas. Please welcome Dr. Miguel Escobar. Hi, Miguel.
How are you?
Hi. Glad you can join us for this discussion. And we'd like to really just dive right into our discussion of extended half-life factor VIIIs. And so, we're going to cover 4 molecules, 3 of which are already licensed that have some similar properties, and then a 5th one that's a little bit different. So let's go ahead and get started with the first molecule, which is known as recombinant factor VIII FC, and less so by its generic name called F-Moroctocog alpha. So what can you tell us about factor VIII FC?
Yeah, as you probably already know, this was certainly the first molecule that got approved by the FDA a few years ago. This is a B-domain deleted recombinant factor VIII that has this linked to the FC portion of the immunoglobulin. And the approval of the molecule was for patients that were treated on demand, also patients that needed surgical procedures, as well as patients on routine prophylaxis, for this population. The A-LONG study, which I think was a pivotal study that they did it in the adults, and they had different arms. They had the episodic arm, which what we expect, high ABRs in those individuals. They have the weekly prophylaxis, and then they had the individualized prophylaxis as well. And there was quite a reduction of about 92%, especially in the individualized prophylaxis and in terms of the ABR.
What did you think of that study design, where the typical study designs have always been either you're on demand or you're on prophylaxis, and here they had these different prophylaxis regimens, clearly with some different outcomes. So what did you think of that?
Yeah, I think, nowadays, we're treating our patients more in an individualized manner, and I think that probably makes a big difference, when we, look at the different characteristics of our patients, the severity, maybe the status of their joints, their activities, and I think that makes probably a lot more sense than just kind of treating all the same. And I think and we'll see in some of the results of the studies that individualized therapy seem to be probably more efficacious than just the regular standard treatment.
Yeah, and I mean it's reflected in the results as well, where you see less. The ABR was lower in the individualized prophylaxis, and that's how we practice really. Every patient is different, and so I think the option to individualize the prophylaxis is important. And in fact, in the label for this product, there's every 3 to 5 day dosing regimen that you can adjust depending on each patient. So yeah, I think the pivotal trial offered us data to support what we already do, which is the individualized prophylaxis. So what can you tell us about some of the other studies? There was an extension study, there's a pediatric study. What about the data from those?
Now, in the long extension study, the Aspire, there were about a little over 200 patients that participated in this study. And again, there were no inhibitors observed, which is something that we're always concerned about. And the ABR remained low in this population as well. Now, one of the interesting things was that at the end of the initial study and as well as at the end of the Aspire, the interval dosing actually increased both in the pediatric and the adult. So I think the overall results, were very, very positive, especially in regards to ABR and to safety, which is our main concern.
So let's move to the next one. This is the second one of these extended half-life factor VIII molecules that was licensed. And what can you tell us about this molecule, Rurioctocog alpha Pegol? So what's similar and what's different about this particular compound or this particular product?
Yeah, this molecule is actually a full-length unmodified factor VIII that has a PEG, which is about 20 kilodaltons or so. Again, when it was approved, it was indicated for on-demand treatment of bleeds for patients that undergo surgical procedures and for the management of prophylaxis as well. Their phase 2-3 trial in patients with severe hemophilia, showed that there was a significant reduction in the ABR as expected. If we compare to the episodic, for example, it was over 40. And now when they compared to twice weekly prophylaxis, the ABR dropped to almost about 1.9. And interestingly also, in terms of safety, there were really no inhibitors that were developed. And I think the reactions that happened were, as expected for this type of molecules, undergoing these kind of studies.
Sure. So to follow on from the discussion of the previous product, so the previous product, they had two different prophylaxis regimens. They had the weekly and then the individualized, which was very flexible. And with this clinical trial really didn't have that. It only offered either your episodic or your twice a week. There was no individualization involved with that. Do you see any specific advantages or disadvantages to the fact that this clinical trial was conducted in this manner without that individualized prophylaxis approach?
Yeah, that's an interesting question. I think a lot has to do, certainly with compliance. I think that is critical. And as we know in the clinical studies, the criteria is very strict. Those patients are followed very closely. So I think also it has to do maybe with the dosing, and we'll see in some of the other studies also that there could be some difference even in the individualized versus just a standard, dosing, either 2 or 3 times a week, whatever the protocol is. But I think a lot has to do probably with how adherent those individuals are.
Sure. And I think, there's something to be said for flexibility. On the other hand, when it comes to putting a patient on this product, it's pretty straightforward. Anything different or unusual about the continuation study for this product?
No, I mean, these were patients either that completed the study, that wanted to transition directly, or even individuals that were naive to the product. They were already being exposed previously to other factor VIII products, could, be part of the study. And the study showed similar results, using the fixed dose, and they also had a PK tailored regimen was quite effective and well tolerated.
Okay, great. Thank you, Miguel. Let's move on to the third product, and this is as well recently licensed product, Damoctocog Alfa Pegol. So this is another pegylated product, but some of the aspects of this product are different than the previous one, and some of the results of the clinical trials are a little bit different. So why don't you tell us a little bit about BA94?
Yeah, this molecule is actually a B-deleted recombinant factor VIII. They did what's called a site-directed mutagenesis, that they introduced an amino acid in a certain position, and it has a pegylated, as you mentioned. It has a 60 kilodalton peg that has been attached to it.
So let's discuss this molecule, Damoctocog Alfa Pegol, a little bit more, because as we mentioned, the first molecule had one weekly regimen and then a individualized adjusted regimen. The second one was that strict twice-a-week regimen. And now here we have a molecule where in this trial there was lots of sort of different approaches and different regimens used. So can you describe some of the regimens and the results for those with respect to Damoctocog Alfa Pegol?
Yeah. As required, they had an episodic arm, which we expected to have a high ABR. Then the other regimens and prophylaxis were individuals were treated twice a week, once every 5 days or once every 7 days. And there was some difference in terms of the ABR. For example, the patients that were treated, for example, twice a week, there was a mean ABR of about 4.1 compared to individuals that were treated every 7 days. Some of them had an ABR of 1, for example. So there could be some difference when you start, making some changes in the dosing and in the intervals of the product.
Yeah, but so what's interesting there is we have some patients twice a week with an ABR about 4 and others once a week. And I think what was done in this trial is that patients were moved according to their investigator from one regimen to the other. So the ones that were bleeding less got to use less factor. In other words, the frequency was extended, and yet they still didn't have a lot of bleeding. So I think what this tells me is that there are patients who are low risk for bleeding, and even if you stretch out the interval between their doses, they still tend to do well, whereas others have more bleeding, maybe because they're more active or have more joint disease, and then if you try to stretch those out, they're still going to have quite a high bleeding rate. So it's another way of thinking about individualization, and this product offers us that data as well that we can consider. So there was an extension study here as well, and I think that based on what we know, there was not much differences between this extension study and the others. I don't know if you have any specific comment about the extension study further than that.
No, just that the ABRs were actually quite low when you look at across the different regimens that were used for prophylaxis. You know, they were actually quite similar, which I think is also shows, you know, how effective these products can be.
Okay, so let's move to the fourth product of this first category of products. This one's called Turoctocog Alfa Pegol, also known as NHEP, and as you can tell by the name, this is also a pegylated molecule. So I think we've discussed PEG enough, but why don't you tell us a little bit about the results from this particular clinical trial?
Yeah, and again, this is a B-domain truncated factor VIII that has a 40 kilodalton PEG. Now, the data that is available so far, one is the Pathfinder 2 study that resulted in a pretty significant lower ABR as expected when you compare to the episodic treatment. There was actually one patient that developed an antibody, an inhibitor against the molecule. But there are really no other safety concerns with the use of this product. Now, the Pathfinder 5, which is the pediatric study, also was very well tolerated and was pretty effective as well in terms of annualized bleeding rate for these kids.
And extension studies, they did extension studies as well?
Yeah, they had, they looked at the pool analysis between the Pathfinder 2 and the Pathfinder 5. And, again, it shows very effective protection in terms of the prophylaxis for those adults and adolescents and the pediatric patients that had severe hemophilia A.
Okay, great. Fantastic. Thank you. So let's shift gears a little bit. So we're still going to talk about a factor VIII concentrate, and we're still going to talk about an extended half-life factor VIII concentrate. But as we know from those four products, there's been a limitation in terms of the extension of the half-life to about 1.5 times the half-life of the standard half-life products. And it's been a bit difficult to overcome that barrier. But along comes a new molecule, really something a little bit different. Again, factor VIII, again, extended half-life. But tell us a little bit about BIV or BIVV001.
Yeah, this is also what we call a fusion protein. So it consists of a single chain factor VIII. They have added or they have bind some of the domains of the von Willebrand, the D1 and the D3 domains. And in addition to that, it also contains what's called the extant linkers. Those extant linkers are polypeptides that consist of about 6 amino acids or so. And what these linkers do, actually, they reduce the rate of clearance and of degradation of the fusion protein in the circulation. So they're supposed to be even having longer half-life than at least the molecules that we know.
Yeah, I think that the idea behind this molecule is really to go beyond that 1.5-fold extension. And as we've seen in the dosing regimens, the majority of everything we talked about was twice a week or every 3 days or perhaps every 5 days. There was a little bit of every 7 days, but really, we don't have molecules yet that are licensed for every 7-day use as extended half-life factor VIIIs. And I think this molecule is trying to break that barrier and get us to that point.
Most of our patients went from maybe 3 times a week to down to 2 times a week. And I guess the idea will be to be able to even prolong that interval further, hopefully to once a week or even more. So I think it's very promising.
Great. Well, Miguel, thank you. It was a great discussion. It's very clear we are in an exciting time in treating hemophilia A with lots of new and different options. When we come back, Dr. Escobar and I will discuss some of the real-world practicalities of using extended half-life factor VIII. So stay tuned, and we'll be right back. Thank you. Welcome back. Building on our previous discussion, Dr. Escobar and I will highlight some of the practical considerations for using extended half-life factor VIII products in patients with hemophilia A, as well as some clinical pearls for personalized prophylaxis. So why don't we get started with that? We talked about several products that are extended half-life products. Currently, 3 of those are licensed. The factor VIII FC molecule, F-Moroctocog alpha, the pegylated molecule, Rurioctocog alpha Pegol, and then the most recent one, Damoctocog alpha Pegol. Can you tell us a little bit, just briefly overview things about their dosing regimens?
Yeah. As we mentioned, some prophylaxis regimen would have been fixed, others have been with some flexibility, and I think that's important for us as treaters, as clinicians, to be able to have that information. Because I think that nowadays we're doing more individualized treatment. And I think that's important to be able to have that flexibility. Because, I mean, you could dose them at a higher dose, maybe every 5 days, or maybe that is individual is having breakthrough bleeds or is very active. You might consider, well, maybe we will use them twice a week to make sure we prevent a bleed. But to still have that flexibility that comes from the clinical studies. And I think that's important to be able to have that information.
Yeah, as well as with, I think payers are also looking so much more carefully at how we prescribe these drugs. And so having ones that have relatively broad dosing flexibility, as you mentioned, gives us really the ability to individualize without getting too many questions, from payers, why using this dose? And say, well, it's on the label for that molecule. And so I definitely encourage, people who are prescribing these drugs, to know the label. I think to know the dosing label, it's a bit different than with the standard half-life drugs, as we discussed earlier. Another thing that comes up with these molecules is issues related to factor VIII assays. And as we know that we may have times when we might want to measure a factor VIII level in patients, surgery or breakthrough bleeding, or just doing pharmacokinetics to establish a dosing regimen. So what can you tell us, just again, just briefly, what are some of your thoughts about measuring these extended half-life factor VIII molecules in the lab when it comes to measuring a factor VIII level?
Yeah, I think we got two basic assays. One is the one-stage assay that we've used, for many, many years. And now we have also the chromogenic assays. For individuals, when they're going to start formulating any of this product, I think it's important to first go to the label and look at the studies, what kind of assay was used, and then talk to their main laboratory, whatever they're going to send the sample to, make sure they're using the right assay to be able to monitor. I think that's going to be the most important thing when you're dealing with this kind of products.
There can be issues with respect to over and underestimation. So tell us just a little bit about what might happen with underestimation and what might happen with overestimation.
Yeah, I mean, if you do an assay that might be underestimating the factor VIII level, then you might be unnecessarily giving additional doses to this patient, and certainly is not needed. It's going to be probably a higher cost and things like that. So I think it will be important to be able to figure out exactly maybe what is the best assay to be able to use in terms of their specific laboratory. And even if their local laboratory doesn't do it, some of the commercial laboratories that have more experience are able to run this test. So I think it's important to be able to match maybe the product with the assay, and that is usually enough to be able to provide monitoring to this population.
Yes, and then with overestimation, the issue might be that you think of a factor level that's 80 or 100%, whereas really it's maybe 20 or 30 or 40%. So you can get into trouble with ineffective hemostasis if, for example, your lab is overestimating the level. So I think that whoever's prescribing it, as you said, they should just be aware which molecule are they prescribing, can their lab measure it accurately? If not, yes, use one of the send-out labs and have them measure it. In those situations where you want to measure levels, I think the one point maybe we didn't make is that routinely patients on prophylaxis, if they're doing fine, there's no reason to measure their levels on any sort of routine basis.
Absolutely, and I think in our case, for example, we use it a lot for surgery.
Okay, so I think the next thing, Miguel, we need to discuss is patient selection. And while maybe all patients may benefit from extended half-life factor VIII molecules, I think certainly there are some patients that we think about using these products in more or earlier. So tell us what goes through your mind as you're deciding on which patients you think may benefit the most from an extended half-life factor VIII product.
Yeah. I mean, as a regular practice in our center, we discuss new molecules with all the population, certainly, especially with the severe patients. But, one of the specific groups that really comes in my mind that could really benefit from this type of molecule are those patients that are not adherent. These are individuals that, they're being prescribed prophylaxis, let's say 3 times a week in a standard half-life factor VIII, and, they're not doing it for whatever reason. They're still having breakthrough bleeds. I think that group is a very good candidate to be able to give it at least a trial for this kind of molecules where, you might be able to decrease the amount of infusion at least to twice a week based on what we saw, maybe even once every 5 days or every 7 days, depending on their pattern of bleeding. So I think that's one of the main groups that we try to target, is the patients that are not adherent. And I think that's when we talk about, especially of those adolescents.
Mm-hmm. Yes, and then, myself as a pediatric hematologist, though I take care of kids and adults, I think of those young children that have difficult venous access, where, even if it's patients with central venous catheters, I mean, there's still a lot of work to do by the families to access those catheters. And if we can go from 3 times a week or every other day to twice a week, I think that makes a big difference.
Absolutely.
In fact, one other category I want to ask you about is, as an adult hematologist, we know that there are many adults who they just don't want to do prophylaxis, partly because of the IV and the treatment burden. Have you had any patients who you've been able to convert, shall I say, from on-demand or episodic therapy to prophylaxis once extended half-life factors have come out?
Absolutely. I think we have many patients actually that have, and as you said, some of the adults, especially the older adults, they've been very cautious in how they treat, and some of them actually don't treat enough, and others probably just overtreat. We have a whole combination of patients. So we've had, for example, patients. I remember one particularly that actually he's been in a plasma derived forever, almost treating almost daily or every other day with a plasma derived product, and I've never been able to convince him to switch to a different product. Now, when the extended half-life products came out, we had a long conversation, and I specifically told him about the mechanism and how it is. So he wanted to give it a trial, and he did. And once he tried it for about a month, I mean, he was amazed what the difference could it be. And and since then he hasn't really changed his management, now being on the extended half-life. I mean, he is one that is able to. He went from being almost every other day to only twice a week. And he's very happy with that. So I think that's certainly another population that could benefit. And we also have some of the older adults that also have difficult venous access for many reasons.
Sure,
And those individuals also could benefit greatly from a molecule like this.
We stress physical activity, and maybe in the past these patients were hospitalized a lot many years ago and in wheelchairs, and were actually more or less put in a bubble, like don't be active, because we really didn't have such a number of effective treatments for them. So what about physically active patients, those involved in sports? How do you feel about extended half-life molecules for those patients?
Yeah, I mean, like I said, we offer it to all our patients, and we've had patients where they decided they feel more comfortable in the molecule they've been for a while, but other patients actually have switched. I think some of them have benefit, the ones that have switched, at least tried, where they might be able to go every other day or even every 2 days or so, and still be able to prevent any type of bleeding and continue with the same activity.
I see. So using extended half-life factors, but giving them as frequently perhaps as we use standard half-life factors, and that enables them to have a higher trough and protects them from sporting injuries without having to perhaps dose every day. So I know for myself in the past, I've had patients who would dose factor every day if they were playing, high school soccer, basketball, or college sports that were very, very active. And I think that I think that's still a very reasonable approach, doing an extended half-life factor, but outside of the dosing label in a more frequent regimen may allow patients like that to dose every other day and yet still have a sufficient trough that protects them from injuries as well. Okay, great. Let's move to really trying to make product selections a little bit more specific, because as we saw, we have 3 products available on the market now, and in many cases, they're very similar with respect to efficacy and safety. They've all been shown to be efficacious for all the different indications we discussed. They've all been shown to be really safe for the indications that we've discussed. So not a lot to choose with respect to efficacy and safety. So how do you make decisions between the extended half-life factors? What are some of the things that might come into play once you are ready to make the switch to an extended half-life factor?
Yeah. A lot has to do also with, maybe patient choice. I think some of the patients might be able to choose one product for another for many reasons. But I think it's important also to see what kind of clinical experience one has. Some of us has participated in many of the studies, so we do have experience with that molecule, and we feel maybe more comfortable using that molecule since, we've used it now for some years. That could be, one reason that we use one maybe over another. Another possibility certainly is it has to do probably with the insurance companies, the approval of one molecule over another.
Sure.
And I think that's something that we're probably seeing now more frequent. And again, maybe the patient choice as well. Because as you said, in terms of efficacy, I think as long as they're adherent, the efficacy is going to be very similar among the products. So when we look at the ABR in general.
Yeah, I'd say in addition to that, from my perspective, and maybe it's coming from the pediatric perspective as well, but that we have two pegylated products and one that's a fusion protein, which is more, so to speak, natural, if you will, using a portion of the immunoglobulin molecule as the extender of the half-life. Yes, formulary cost, I mean, that's definitely becoming more in play. I know that some payers will only offer one extended half-life factor or two out of rather than more. And I think given the efficacy and safety is the same, if a patient wants to use one and their payer insists on using one brand versus another brand, I think that's okay. We don't like when anybody interferes with a doctor-patient relationship, and we prefer to make the choices totally freely. But sometimes our hands are tied. And I think in this case, again, the comparative safety and efficacy seems to be similar.
Pretty similar.
There aren't any head-to-head studies, but it seems to be really quite similar. Great. I actually have a couple of examples myself. One is more straightforward. The other one's a little bit of a different use of the product. The more straightforward one is, and you alluded to this earlier, it was a patient, he's about 8 years old. The mother and father are very busy. They run a school, so they're up 6 in the morning every day, getting to the school and running their private school. And this young boy with hemophilia, educated parents, obviously you're running a school, you're educated, they understood that he should get his factor every other day. But the mom just couldn't do it. She said, well, Dr. Young, I can get 2 doses in a week because there's 2 days I can get in a little bit later, but it's impossible. I can't do it more often than that. And he was bleeding. He had, his ABR one year was 6, another year was 8. I mean, he was having a lot of bleeds and bleeds in joints. And I was telling her, your son's joints, they're going to get damaged. Anyway, she just couldn't bring herself to dose it more often. So then when Factor VIII FC came out, it was the first extended half-life factor. I said to her, okay, look, if you're only going to dose twice a week, I said you need to switch to this product. She was maybe a little bit hesitant, but I really insisted. And I said, no, you're only dosing twice a week, you need to use this one. So she agreed, and they switched, and his ABR dropped significantly, really to the rates that we saw in the clinical trials, down to about 1 or 2. And so I think it's really made a big difference for them. The other patient actually is the one with a low-level inhibitor. So he had a high-titer inhibitor. He's basically partially tolerized, so he has a short half-life. And they had to dose every day. If they were not dosing every day, he was getting bleeds. And to dose every day as a young kid, who's like 3 years old, they had an externalized central venous catheter. And so, he couldn't go swimming, and they'd worry about it getting wet, and we had worries about infections. They had been on a certain standard half-life Factor VIII product. And then we switched him to one of the extended half-life products. We said, look, why don't we try this? Maybe, just maybe, we can get to dosing every other day, even though there's still this low-level inhibitor. And so we did switch him. We did measure levels, and we were able to get a trough of about 1%, sometimes 2%, at every 48-hour dosing, so every other day dosing of an extended half-life factor, which was pretty well enough for us to switch him to every other day. And the biggest difference for the family is not having that external catheter. They're always worried he was going to pull it out, or it was going to get wet, he couldn't go swimming. And so that was a sort of unusual or different kind of use of an extended half-life product that I think really has benefited the family. So I think the last question I have revolves around personalized prophylaxis. We talked a lot about that at the beginning. So what is your approach to personalizing prophylaxis or doing any sort of individualization of prophylaxis?
Yeah, I think that's what a lot of treaters are now practicing, where we don't kind of do just a fixed dose that we used to do maybe 10 years ago. I think we all did that. But I think nowadays we look more at a patient as a whole. We look at what their severity is, certainly, what their joint status is. We look at how active that individual is. I think that makes a big difference. You have somebody that doesn't really do much, but if you got one of these kids that are just playing all different sports, I think you need to make some changes to that. And then in addition to that, I think we're doing now more PK studies, if we say so.
Yes.
I think we're being more conscious about, those trough levels probably. I don't think we know what is the ideal trough, but I think we have some idea of maybe how to put all these variables together to come to that main goal, which is, a zero ABR if possible.
Yeah, I totally agree with you. We actually really essentially require patients to undergo at least a limited, 2 or 3 levels PK pharmacokinetic evaluation when we switch them to extended half-life factors. And as you said, while we may not know what exactly is the right, most perfect trough, I think knowing the trough for a patient, knowing their half-life, it's very helpful. Exactly. It's very helpful because, if they're having breakthrough bleeds or if they're having bleeds with activity, you really understand that. And using the PK tools available, there's online tools, there's also tools that some of the companies have put out as well, that using those tools to really generate that curve so you know where a patient is at any given time, I think is helpful for us in decision making. So yes, we are definitely in an era of personalizing the approach, and I think measuring levels does help. I don't think it's required. I wouldn't say to anybody watching this or thinking about putting something on extended half-life factor that they have to measure levels. I think it's beneficial, and I think people should consider that. But I wouldn't use that as a reason not to prescribe an EHL. If somebody is in a smaller center, their labs aren't, they can't get levels as regularly, or a lot of times patients or parents may refuse. I don't think that's a reason not to prescribe it. But for sure, it's helpful if you can do that.
Yeah, and I think also having the flexibility of all these molecules based on some of the studies, I think that's also very helpful.
Well, Miguel, thank you so much for this discussion
thank you.
today. It's been really interesting and enlightening. I always learn things when we have these types of discussions. I hope the audience has learned something as well. So thank you very much. EHL factor products may encourage patients to switch from on-demand treatment to prophylaxis, reduce the burden of frequent IV injections, reduce the need for central venous lines in children, promote adherence, improve outcomes, and potentially allow for a more active lifestyle. Patient cohorts that would most likely benefit from EHL products are those with poor adherence to standard factor regimens with or without difficult venous access, those who are physically active or involved in sporting activities, and patients with a severe bleeding phenotype. I would encourage you to monitor factor levels during treatment when possible. EHL factor products should ideally be monitored using an assay that accurately measures the activity of a specific EHL product. The dosing schedule of EHL factor products should be personalized, not only to measure factor levels, but also to joint status, individual bleed pattern, lifestyle, and physical activity. Thank you all once again for joining us today. This is Guy Young signing off.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/XAQ. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.